PALOMA-2 is assessing amivantamab subcutaneous formulation, and it was really interesting to see that in PALOMA-2 we have multiple cohorts depending on the setting in terms of previous treatments, type of EGFR mutant non-small cell lung cancer, combination with lazertinib or even chemotherapy. In this cohort that was presented at ELCC, 26 patients were enrolled in this amivantamab single agent cohort number 4. And those patients received amivantamab subcutaneous after amivantamab intravenous formulation. Very interesting to see that the duration of amivantamab subcutaneous was quite long, more than 7 months. It was only 3 months for amivantamab intravenous. So it was a kind of rapid switch to subcutaneous formulation. And there was a questionnaire to assess the impact of the subcutaneous versus intravenous on physical functioning, psychological functioning, all the dimensions of quality of life. So the results show that the safety profile was quite similar across the two arms, similar pharmacokinetics. So that was clearly showing that we can switch from IV to subcutaneous with high standard of security. And if we look at the quality of life assessment, well, it was really better with the subcutaneous formulation in all the dimension. And when amivantamab IV was seen in about 25% of the patients as being associated with some inconvenience and these kind of things, well, we see that with the switch to subcutaneous, we do not have this kind of reporting from the patient. So it actually shows the subcutaneous formulation should probably become at some point the standard formulation for majority of patients. We have similar actually reporting with subcutaneous immune checkpoint inhibitors, and we saw during ELCC some data with pembrolizumab subcutaneous with exactly the same type of reporting. So there is a global trend in lung cancer towards subcutaneous formulation of innovative therapies and antibodies. So it's clearly what now we have to integrate into clinical practice, and also organizations. It may be delivered at the hospital, but probably through a kind of fast-track subcutaneous organization. It also opens the window for at-home administration of amivantamab, and this clearly should even facilitate the quality of life of patients and organizations. So we had previous reports regarding the subcutaneous formulation being less associated with infusion-related reaction, possibly associated with more prolonged duration of treatment in combination with lazertinib, and also some data maybe showing some more limited cutaneous side effects. So clearly, the subcutaneous formulation has many advantages and probably will be prioritized at some point by the prescribers. PALOMA-3 is amivantamab plus lazertinib combination in the late line setting. So after failure of third generation TKI and chemo, like the Chrysalis phase 1-2 trial population. PALOMA-3 is clearly the key trial showing the similar pharmacokinetic of amivantamab subcutaneous versus intravenous, also with similar reporting regarding quality of life, duration of hospital stay of the patient. Clearly, the reduction in the risk of infusion infusion-related reaction facilitates that, because if you have an infusion-related reaction, the patient has to stay for monitoring. You can re-challenge amivantamab, but at a lower rate, so it takes more time. So clearly, subcutaneous facilitates also these organizational aspects. In terms of efficacy, we see similar efficacy, maybe slightly better with the subcu formulation. I really feel that this data shows the value of amivantamab plus lazertinib in the late line setting. It's not really the label of this combination right now, because the label is based on Mariposa in the first line setting, and we expect the adoption of Mariposa in conjunction of the formulation of amivantamab with a subcutaneous administration. Well, we expect a majority of patients to receive amivantamab across the treatment sequences and in combination with lazertinib in the first-line setting, in combination with chemotherapy post-osimertinib. We see that we have now many new options in this setting, including combination of chemo plus Osi, Mariposa with amivantamab plus lazertinib in first line. Second line, many new options. We have already Mariposa-2, chemo plus amivantamab post Osi, which is standard of care. We have seen the ivonescimab data, bispecific immunotherapy plus anti-angiogenic drug. We have data with antibody drug conjugate, patritumab, datopotamab deruxtecan. We also have some data with new agents, including the targeted agents against MET, such as savolitinib, requiring a selection based on a biomarker identification. So there are many options. We need to know what is the best way to sequence those options. I strongly believe that targeted agents and agents targeting EGFR should be used as early as possible. We know that it's better to use the most effective agent as early as possible. With Mariposa, we have a benefit in overall survival. This is what we want as oncologists. It's what we have always done, is prioritizing treatment associated with significant benefit in terms of overall survival. This is what we have with Mariposa. So at the end, this is what I expect the adoption of the amivantamab plus lazertinib combination for the vast majority of patients with EGFR-mutated non-small cell lung cancer. We will learn more about the sequencing through these cohorts. Is it better to give, is it possible to give amivantamab as a re-challenge? How can we switch from combination to single agent? There are many open questions actually in the sequencing of treatment, not only for patients with common EGFR mutation, but also for patients with uncommon mutations, exon 20 for sure, but also we had seen last year at ASCO some data in uncommon mutation apart from exon 20. Patients with MET alterations are also some patients of interest for this drug. So many subset of patients that now that we have the landmark key phase 3 randomized study, it's time also to explore what would be the additional patients who could benefit from amivantamab as single agent or in combination.